Okay, well, let's just wait a minute.
Welcome. Welcome. Thank you all for your patience. We will be beginning in just a moment.
Good evening, everybody. I'm Dr. Catherine Meeks, the Executive Director of the Absalom Jones Center for Racial Healing, and we are so delighted that you are choosing to join us for this wonderful topic of maternal and infant health and care. And we have a wonderful group of people to help us with exploring this topic tonight, and we are really delighted that the Center for Racial Healing is able to continue to explore these issues and topics underneath the umbrella of looking at health disparities and how that impacts the whole construct of the racial healing and how that's related to systemic racism, because we tend to separate things out in ways that are artificial. And we believe at the center that a holistic approach where we look at all of the intersections of like health disparities and immigration and prison reform and all of that goes together in looking at systemic racism. Otherwise, you're just kind of playing a game if you think you can pick and choose, because that's not how it works if we intend to ever get to sustainable dismantling of racism in this country. It's my honor to introduce our program manager, Dominique Hardy, who will tell you a little bit about our technical setup tonight, and then I'll introduce our moderator and we will get going.
Thank you, Dr. Meeks, and welcome again, everyone. It's such a pleasure to see you all virtually. As it relates to technology, if for any reason there are any interruptions at all, please take a deep breath, calm down, sign out, and kindly sign back in using the same link that you initially did. And please give us 3 to 5 minutes to resume. And then also, periodically throughout the conversation, we invite you to put your questions and answers in the Q&A box at the bottom of your screen. Unless you have a tablet, most of you all should see the Q&A box at the bottom. And then obviously you see the chat as well at the bottom for any comments that are not Q&A. If you have any other technological concerns throughout this conversation, please feel free to just put it in the chat or private message me. Again, thank you for attending, and Dr. Meeks.
So it's my great pleasure to introduce Dr. Jennifer Gander, who is a clinical epidemiologist at Kaiser Permanente Hospital Systems in Georgia, and someone who I'm not used to interacting with scientists that have such great hearts. And so she brings a great heart to the scientific part of her work in this world. And that great heart led her to contact me to see if there would be some interest in the center trying to do some collaborative work with Kaiser. And it's been an amazingly wonderful collaboration and connection, for which I'm deeply grateful, Jennifer, for your enthusiasm, your energy, and your commitment to health and wellness, and your willingness to spend a lot of time thinking about ways in which we can collaborate. So thank you very much for being one of the most unusual scientists I have ever encountered. And I'm delighted to welcome you here tonight as the moderator for this marvelous panel.
Thank you, Dr. Meeks. I think I'm going to add unusual scientist to my signature line. That's probably one of the best compliments I've gotten, so I appreciate that. And I don't want to start off this town hall with tears, so I'm going to jump right in here. Thank you so much for that introduction. Thank you to everyone who is joining us this evening for part 1 of a 2-part series on a very important topic around maternal and child health. I am honored to introduce to you 4 very esteemed panelists from the Atlanta area, but have expertise that span, across our state, across our region, across the country. I want to one by one kind of let them introduce themselves, and then I have a couple of discussion topics, but I'd love for the audience just to, let's make this as informal and round robin and town hall as we possibly can. So between Dominique and I, we're going to be monitoring the chat. So please keep the questions coming. And with that, I would like Dr. Tina Davis to do a brief introduction of herself.
Hi, good afternoon. I'm Tina Davis. I'm a behavioral scientist at Kaiser Permanente, Georgia, and I'm really excited to be here. And I feel like I represent two hats when I talk about maternal and child health because I am a mom. I was a researcher first and then became a mom. So still sorting out what those mean to be together and have my own experiences and perspectives, I think, from being a patient multiple times and I'm also being a scientist and kind of thinking through what it means to understand disparities and be part of the solution when you've also been the recipient of some of the challenges. So I'm excited to be here and look forward to wearing both these hats with you all.
Thank you, Tina. Next, esteemed panelist is Dr. Ericka Gibson.
Hey, good evening, everybody. It's great to be here, so thank you for inviting me. My name is Ericka Gibson. I am an OBGYN with Kaiser Permanente. So I've been with Kaiser for going on 5 years. I also have the privilege of serving in an administrative capacity. So currently I'm the Associate Chief for the Women's Services Department and will be transitioning into the role as Physician Director for perinatal safety and quality. So in that space, worked a lot, on the initiatives that we've started within Kaiser to really, look at how we deliver, perinatal care, postpartum care, really rethink and redesign the way we deliver care to maximize, safety, quality, and really thinking about, how to address some of these inequities. Like Dr. Davis said, I'm a mom too. So, also being able to come home and be with my babies really kind of solidifies, sort of why it's important that we're doing what we're doing so that we give every mom the chance to be able to come home to healthy babies.
Thank you, Dr. Gibson. Dr. Natalie Hernandez, if you don't mind introducing yourself.
Absolutely. Good evening, everyone. Excuse me. Natalie Hernandez. I'm an assistant professor in the Department of Community Health and Preventive Medicine at Morehouse School of Medicine and the executive director of our Center for Maternal Health Equity, which was actually established in 2019 to address the maternal health inequities in Georgia. Our vision and the work that we do is to end health inequities and women's health across the lifespan. And we do this through translational research aimed at understanding prevention and reduction of maternal mortality or morbidity among BIPOC women, interprofessional training, outreach and community engagement, policy and advocacy, and innovative, respectful healthcare. So I'm just pleased to be here. I'm also a mother. This work is so personal for me. I come from the South Bronx, which is one of the poorest counties in the United States, and have experienced inequities my whole life. Even as an academician, it doesn't stop when you have a PhD. So I'm just really pleased to have these conversations.
Thank you, Dr. Hernandez. And last but certainly not least, Dr. David Jones.
Thank you, Jen. I'm David Jones. I'm a pediatrician. I have been with Kaiser Permanente for 20 years as of this past January. Time flies. I did my, I remember in med school, when I did my first rotation in pediatrics, I knew immediately that's what it was a career for me. And I haven't, questioned that for a second since then. I feel a bit at home with this panel. So my dad was an OBGYN, my mom has a PhD. So I feel a little bit of both being channeled here. So it's really exciting. And I've had a few different administrative roles, the privilege of administrative roles with Kaiser Permanente. Probably the most challenging and gratifying is the chief of pediatrics for about 5 years. And so I'm really excited to be here with everyone.
Thank you, Dr. Jones. And thank you to all of our panel members for coming out this evening and making time. As the participants, I hope you all can see, We've tried to thoughtfully and mindfully put together a diverse set of panel members that bring together a lot of different experiences to discuss this important but broad topic. And on that, I kind of want to, I kind of want to dive into the discussion, but I'm curious, as we go through this, I'm curious if any of the participants or panelists, if you've ever experienced, you've been at a playground or a park and you've ever seen two parents, especially usually moms, meet like for the first time just by happen chance because their kids are playing together. It's almost like within the first 5 minutes, they will have introduced each other's kids. They will have learned each other's kids' names. They will probably have shared pregnancy stories, labor stories, the trials and tribulations, any barriers and challenges that their kids are suffering, how much they did not sleep last night, all probably within the first 5 minutes, all probably before like exchanging each other's names, right? Like that's just, I mean, it's amazing. It's this great community that kind of comes together. At the same time, I feel like some of these stories that, being a mom myself and being out on the playgrounds so often in the past 2 years, the stories and the challenges, like, wow, like they just keep coming and coming. And I feel like, it's not just this one off and this one mom or this, one family that's had a hard time. It seems like these problems, these barriers, these challenges for moms, maybe even before pregnancy, like they just keep increasing. Same thing for infants, same thing for children. The numbers, the CDC, the statistics, they're all in agreement with my anecdotal like conversations that I've been having, right? Just out in the community. Maternal mortality continues to go up. It's kind of actually plateaued, but it's plateaued at a really high rate. And so it's not going down. It's worse. The United States compared to the rest of the developed countries, like we're towards the bottom. If you look at Georgia and the Southeast, we're towards the bottom compared to the rest of the United States. And unfortunately, that disparity, that geographic world disparity doesn't stop there, right? Even within Georgia, when you look at different moms from different backgrounds, from minorities, education, age, it gets worse and worse for the maternal mortality, and infant mortality is the same thing. And so this has, this conversation, I think, really started around like 2016, 2017. It really started being brought to life because you saw that no matter how much education, no matter how much social network someone has around you, they are still facing, just like Dr. Hernandez, just like Natalie was saying, at some point in time, it doesn't matter how much education you have or what your income is, like there are still these barriers, there's still these gaps, there's still this discrimination. And so thank you all for coming to this. And I think one of the first things I want to kind of discuss is just anecdotally, right? You all did a wonderful job introducing yourselves, but anecdotally, I'm curious if you all can share from each of your all's perspective and each of your all's experience, kind of just what problems and challenges either you've seen personally or you've seen among your colleagues and peers or patients or community members for moms and children. And like, am I crazy? Is it getting better? Is it getting worse? Is it just like stagnant high? What are your all's like, what are your all's thoughts? What are your all's playground thoughts?
So Jen, I think some of it is making sure that the beauty of having this national conversation is people start to slowly realize they're not alone. And so that's why you see a lot of the conversations escalate in a way where it feels like it's reaching fever pitch, but it's like the work that has to happen to be able to continue to have these conversations and people know, like, I'm not alone. And I think that shared experience is what helps people continue to share and talk about it, and hearing those stories is even therapeutic. And like you said, meeting those moms and talking about those moms, and even in the moment, you don't realize something is traumatic until someone else talks about it or you reflect on it, right? And so my second son was an accidental home birth, right? Like he was born in the bathroom by true accident after being sent, I was sent home. And at the time, it didn't feel traumatic, right? At the time, I had no fear because I was just like, what is happening? But the more I reflect and the more I talk to other people who've had these accidental things, the beauty of it is still there, but then you start to process that. And I think that's important for people to have those moments And we have these like micro moments of kind of like therapy that are helping, I think, us as a system think about how we can address those, but also help people kind of formally have that time and that space to know that this is something to talk about and that we will work to address. So, you know, I love hearing those conversations. I love having those conversations for that reason.
Yeah, I would have to agree. I think the biggest thing that I'm hearing is about the mental load. I think a lot of us are experiencing it, and particularly in what I call the dual pandemics. You have the racial reckoning and COVID-19, which exacerbated a lot of what's going on. And I've seen a whole bunch of op-eds that are just saying like, I'm effing tired, you know, I'm just stressed, I'm overloaded, the expectations are still the same, although I'm not getting any better or the situation's not getting better, but I'm still asked to work in the same way, like if there wasn't a pandemic happening. And, you know, we're trying to heal physically, but also mentally. And then it's just so difficult. And Tina mentioned the trauma. I'm actually doing a story collection of women's near miss experiences. So that's when women almost died from a pregnancy complication. And, you know, a lot of them haven't healed. A lot of them haven't healed from the trauma of almost dying and then acting like I almost died and now I'm expected to take care of a child and move on with my life. And there's not a lot of services. There's not a lot of mental health support for people, and particularly for us as people of color, you know, having a physician that looks like us or a mental health provider that looks like us, it makes a huge difference. So those are sort of the stories I'm hearing at the playground and the conversations I even have with Dr. Davis through text messaging, but also with my research and what I'm doing. So it's all around. To me, I would say the biggest thing right now is mental health.
Yeah, you know, Dr. Hernandez really brings up a really interesting point about the sort of trauma around, you know, some of the experiences that women have, you know, be it from even, you know, a miscarriage, losing a pregnancy, you know, having just sort of a traumatic, experience. And even if they didn't have, you know, necessarily like a horrific complication, but, you know, I think a lot of women come into pregnancy and come into their delivery experience with very sort of set expectations of how they want things to go, you know, and then when they don't go that way, there is some, you know, sense of trauma behind that. You know, and one of the things that we, you know, have worked on, you know, within our system is, you know, really providing some of that, you know, support to those women, you know, and when we looked at our maternal you know, deaths, when we went through this process of redesigning our, you know, prenatal and postpartum care, you know, some of the deaths and just sort of knowing our patient population and that trauma that women experience, you know, during their pregnancy or with a delivery, you know, we really recognize the need for having, you know, a licensed clinical social worker within our department. So having someone who, you know, really, you know, has specialized training, specialized interest in, you know, pregnant women and these types of issues, and really referring, you know, patients to the social worker so that she can, you know, provide that support and even serve as a bridge to behavioral health. So I think that that was a really, you know, important point, and one of the things that we're definitely recognizing and seeing and trying to address. You know, one of the other things that I hear, you know, a lot from patients, you know, and I've definitely noticed it a lot more, you know, in the past year is, you know, I think just with all of the media attention on maternal mortality, specifically, you know, the disparities and outcomes for Black women or women of color, you know, is really this heightened sense of awareness for patients. And so I've had people, you know, ask me or ask other providers point blank, like, what are you going to do to keep me from dying, you know, in childbirth? You know, people have come and had specific, you know, concerns about certain providers. You know, there's this sense, you know, that I hear often of women, you know, feeling like, you know, they want to be heard, or, you know, in situations where they may have had, you know, a difficult delivery or pregnancy, feeling like they weren't heard. So I think that, you know, space where women feel like they're, you know, heard, listened to, and that they're respected, you know, is really important in, how we care for patients and addressing the inequities and outcomes.
And, Dr. Gibson, I think it brings up another point for me always, which is, Natalie, I love that you're doing narrative work, because the fuller the narrative, I think the more it helps people. Like if we can go in recognizing the both and of pregnancy and childbirth, and recognizing, yes, it is beautiful and yes, it is tough, right? And then talking about women's experiences, I think the better we can fill that out. That's why I love your narrative work that you do, because I think all those stories have to be told and shared.
All excellent points here, and I can add my perspective, which is a little different from everyone else's, which is good, I'd say. So, as a pediatrician, I have the privilege actually of rounding in the hospital postpartum and seeing the newborns, right after delivery, which is both great and exciting, but also I can, in some ways, get a sense of some of all the emotions and fear and excitement that, of course, the postpartum mothers feel and the families do as well. And then, and of course, there's a high concern for the care of their, the health of their newborn as well. So, and there's expectations around that is important to navigate this. So I think it's I feel it's a very privileged position to be in, to really get a sense of what families go through in those moments that can be very exciting, but also very scary at certain times. And then also after we see them in the office, also we have the opportunity to, fully understand, help support obviously the child and the parents help them be, as good, best parents they can be. Over time, I've had an increasing respect and appreciation for, not only looking after, the newborn, but also the parents, and then the mother in particular. Obviously, issues around postpartum depression are very real and very, very difficult for many, many women. And just having the awareness of asking of how are they doing, and just asking the question, I think sometimes just makes a difference to be seen or heard or just appreciated or valued. And I think that, and the more I can respect and appreciate that, the more I think the better I become as a, caring for, as a pediatrician in general, and realizing and appreciating, some of the challenges people go through that they may never, have the words to say, or even the emotions or courage to say. And so it's a different perspective. And then but it's also, it's the beauty of the sort of maternal child, it's a continuum, if you will, right? And I love the fact that there's such a powerful connection in that space.
And thank you, David. Yeah, I think these comments are really powerful, and I appreciate you all sharing your perspective. We already have a few questions coming in, and this is a really great question, and so I want to make sure that we ask it, and then I might actually piggyback on it to kind of segue into, David, what you were talking about. So the question in the chat is, how do we dispel the myth, right? That as moms and Black women, right, that, Black women are just expected to be strong, right? The strong Black woman, and just get over it. Or moms, Dr. Gibson, as you were talking about, you just, you're supposed to have this big traumatic event, and then you just get going on with your life. What is, like, how is mental health important with that, as well with the physical health recovery? And what I'm curious about is where, Dr. Jones, going back to what you said about the continuum of care, right? Like, who's responsible for whom when, right? Like, it's such a, I always felt like, just as a mom, even, with the healthcare and the insurance that I have, it was almost like a awkward handoff of, like, who am I supposed to go to now, and who am I supposed to follow up with, and where does the baby go, and where am I, and I'm just like crying right on the kitchen floor. So, like, where, how do we partner this together? How do we make sure that, we're taking care of the mom, we're trying to dispel this myth of, like, the strong Black woman, or the just get over it mentality, while also making sure that they are equipped, the parents, the caregivers, the mom, are equipped to care for this new life. And who does what? Who's on first? What's on second?
I think I love that question. And I think, again, with this narrative story collection, it's just, sometimes we just have to be vulnerable. We're taught that you have to be quiet, that you have to deal with it. There's a scientific definition, the superwoman schema, that Black women are strong and resilient. And, we're not, we're vulnerable. We have feelings. We need to talk to people. But I think within our families and supports, they don't know how to talk to us. I've been conducting focus groups with Black fathers and with grandmas and aunties and cousins, and they often don't know what to do or are not able to recognize that there may be an issue. And so we're talking about communication techniques, how to really be engaged and be open, because also seeking a mental health provider, there's stigma attached to that as well. And so sometimes we call on Granny to be our mental health provider, or even sometimes our next door neighbors, because some of us are isolated from some of our families because we move on. So what women have been telling me that has been therapeutic is sharing their stories, being able to tell their truth. And oftentimes Black women or people of color aren't able to do that because we oftentimes, and not a knock on quantitative data, but oftentimes we don't center the experiences of the oppressed populations, and we need to be able to do that and empower them to tell their truths.
And I think too, when, in helping people be open, Dr. Jones, you said, just sometimes asking how people are doing. There's so much literature on, like, you could ask the simplest question and that's all that is needed to give someone that moment to ask back. And so it's like taking a beat, and if, having providers and wraparound services and others that are available and have that moment. And, it's retraining the system to think about how we can shift that time. If you only have X amount of time in that visit, what is the most important information, right? You've got the vitals, but now are you asking, how are you? I remember very early in my daughter's pediatric visit, the doctor looked me square in my eyes. My child's pediatrician looked at me and said, "How are you?" And I was like, "Do you see the tears? Did they come up already?" Right? Like, it was simple. And I was, and they do the assessment. And so I love that it is getting asked, and, pediatricians are asking parents, right? And OB is asking, and these systems are happening. And the more we can continue to connect, that we're asking, and multiple people asking, because you never know who someone will connect to is important. And having those faces like Dr. Jones and Dr. Gibson who look like you in the visit just does wonders for parents.
Yeah, Dr. Davis, I was actually going to say the same thing. I think that asking the question is really the, most important step. And, you're right. There are, some OB providers who are going to be in tune to that and some who aren't. So the way you sort of, institutionalize that is by, making sure that we're screening and asking the questions really multiple times throughout the pregnancy. And so that's one of the things that, we really have done is increasing the screening. So we screen these women, 4+ times during their pregnancy, so that you're asking the question. You're right. There might be that one person who, is looking at the form and may ask a specific question that, gives that woman the space to open up and really talk about her experience. And I think, the next question then becomes, okay, well, once you ask the question and you've got someone in need, actually having the resources to refer that person to someone. So that's, again, why our licensed clinical social worker was so important, because, there's definitely, a lot of people tugging at the behavioral health system, and it's, access to, getting, into that system is really difficult. So, the licensed clinical social worker can, again, be the bridge, help start some of those conversations with those women. And I think ultimately, what I think would be helpful, and one of the things we're looking at is, really creating some, pregnancy support groups. So, places where, moms can come together, share those stories, kind of recognize their story and someone else's story, just to create, again, a safe space where, people can, talk about their experience, so they realize that they're not alone.
Dr. Gibson, just a quick question about kind of the support groups. Are you thinking, as you all bounce around that idea, and thank you for bringing that up, is that, are you thinking that's like during pregnancy? Is that prenatal? Is that postpartum? Like, where is it the entire spectrum? Where could that get plugged in? Or where would you maybe where would you start, right? Like if you can't have all of the focus groups, where would you start?
Yeah, so I mean, what we're starting, really the focus is, on exactly this issue, so mental health and pregnancy. So, dealing with helping moms with, depression or anxiety, or these, traumatic experience both during the pregnancy and postpartum. So we're still kind of in that, brainstorming phase, but that's something that we're planning on doing because we recognize the importance of having, sort of patients be able to support each other.
And I saw a question about what about women that don't have access to care? I know that there are, community groups that are doing some stuff, Healthy Starts that are, located and serve low-income women throughout the country. Have these groups called sister circles. I had put it in the chat where they have like patient advisory groups that come together and hold their own sessions, and they have volunteer licensed social workers or therapists that come, but also train the women. So they're using these models of train the trainers so that the women can lead these groups, because oftentimes they still don't feel open to sharing their experiences when a provider is there, even though that's the therapeutic part. But again, just wanting to be heard and having these conversations with women who have similar experiences has been proven to be very powerful. And there are a lot of resources and Black mom support groups through Facebook. And what people find therapeutic sometimes is just, some people find Black Twitter therapeutic and putting their stuff out there, and social media. It's hard because you cannot monitor and determine whether someone is suicidal or there are, significant threats that are happening. But at least for some of the women, this is an outlet. And I think there's more attention to particularly women that don't have access to care, and more resources bringing forth to these populations.
Thank you for that, Natalie. And I'm curious, David, can you talk about, you've already kind of mentioned, kind of taking the mom under your wing and asking those questions, even when they're bringing the baby in for like the 1 month checkup. But what have you seen as a pediatrician, kind of the ripple effects, right, of some of those conditions or the mental health diagnoses that kind of go untreated if you don't ask the question, like not only for the mom, but like what can that have adverse effects on the child, and what does that look like?
So great question. So the answer is yes. There are some ripple effects of having those issues either not surfaced or addressed or supported, and it's not just one conversation too. It's a conversation, asking the question, and understanding this is a process for the parent, whatever it is. One of the elements that comes to mind with your question was around just mental health issues in general, and as it relates to, I think you mentioned about the idea of ACEs, or adverse childhood events. And for those who aren't aware, or experiences, adverse childhood experiences comes out of, it's been well documented for probably almost 30 years now. And the evidence over time has shown that there's several different types of childhood, let's say traumatic events that, especially if they happen over and over and over again, or repeatedly or chronically, not only traumatize the child in the moment at that time or the family, but also is additive over time and can lead to adverse behaviors or risky behaviors or things like that, and that could then lead to and do connect with some significant health issues like asthma, diabetes, heart attack, and so forth. And back to your question, mental health issues that are unaddressed is actually one of those adverse events that is probably one of the most underappreciated and probably underrecognized adverse childhood experiences that is really problematic, because it's not just a quick fix, with one counseling session or a conversation or medication or things like that. It's understanding the current and maybe more broader long-term systems in place, or lack thereof, if you will, that may be driving some of these elements. So it can be very challenging in many ways, for not only the parent, obviously, to have an issue unaddressed, but generally those types of things get worse over time, unfortunately, and it affects whole family unit, both close and extended.
And sometimes, oh, sorry, go
No,
ahead.
sorry, no, go ahead, Tina.
Well, I was just thinking, I remember fantasizing when I had my kids that I would love for there to be one place I could go for all of us to get our health care, because I think one of the things we underestimate is how difficult it is for moms and babies to kind of get care, because the pediatrician does one thing and you have to go to OBGYN for your follow-up, and so I hope that at some point we're able to create even these like mini clinics for moms and babies to think about having some of that support that is done at the same time, because it's such a load. And we often don't think about even how much how much pregnant moms, new moms, and new babies need healthcare all in different places.
Yeah.
Right. And so thinking about how to streamline that could even be, I think, helpful, because as Natalie mentioned at the top of the conversation, there's a lot to balance, period, emotionally. And then you add the physical balancing act. And I don't know if we pay enough attention to the load in that way as well, as and we're getting there when it comes to making sure we're checking in with everybody who's physically there, but maybe think about how we can do mother and baby together.
Yeah, I think that's a really good point. And almost, so I can't get this like term out of my head that Natalie, I think you used about like the dual pandemic, right? That like everyone feels overwhelmed, but like that feeling of overwhelming is disproportionate, right? There are more people that feel overwhelmed than some other people. And so, David, going back to what you were saying, I kind of want to start with you, and then I want everyone else to jump in. Like with COVID and everything that we just discussed, like the mental health, the maternal health, and not feeling heard, now starting to kind of feel our stories. But then Tina, exactly to what you were saying about just the physical load of like shuffling everyone from here and there. David, kind of starting with you, and then everyone else can jump in. Like what has COVID done to all of this? Yeah, I'm just gonna, before I add any expletives, like what has COVID done to all of this?
Exactly. I'll just pick an area because there's so many to choose from, right? And others can probably elaborate on this more. Just when I see, particularly in the office, I see the parents who are wearing 5 more hats than before. They're the parent, they're the teacher, they're the therapist. I mean, they're just so. Every hour is different sometimes, and you get multiple children with different needs, and it's just there's so many. The juggling act is just faster and more balls to juggle. What I've seen, I would say on the positive side, I would say I've seen more awareness across the board and respect and appreciation for mental health issues. I've seen this is gender bias, but I've seen more fathers come in with their kids and say to me, even I've had to see a counselor or therapist. And so I think just not only for themselves, just some of the stigma in some ways is less than it was before, just saying I need help, or just acknowledging this is more challenging than I even thought I could ever deal with. And then on top of that, in the extension, we've seen more anxiety and stress and depression in adolescents and children, which is unfortunate. However, I think the lower the threshold that parents have for getting their children help or asking for help is a good thing. So we got to make sure that threshold stays low and the rates of those issues go down as well. So I think there's a positive shift in the awareness, and we just got to make sure the systems are there in place and we can get people help that they need.
Yeah, and I also like to think about it in a positive way. I think COVID has taught us to be creative in how we deliver care to people. I think, and with policies being loosened so that people now can receive more telehealth services. I know, that physical, visit, it would never replace it, but at least for a woman in the postpartum period who has a lot of barriers and access to transportation and has a child and has to carry that child for an appointment that's so quick, telehealth was something that was great. And again, people thinking creatively about patient navigation and applying that to other fields. I think it gave us an opportunity to integrate technology and really think creatively about how we want to address issues. And also, I think sometimes being behind a screen makes you more vulnerable and honest too. Like now I got, you know, I got some galls to tell you exactly how I feel and what I want to do and be more empowered. I think there was a lot of misinformation and disinformation, but also a focus on communities of color, right? Now we have an opportunity to shine. Now Black lives do matter. And it took COVID and these experiences for that to happen. So I like to always take a strengths-based approach, and I hope that's okay.
Yeah, Dr. Hernandez, I was going to say the same thing. I think, you know, one of the positive things was, you know, really transitioning quickly to using telehealth. And we found that, you know, we were able to, you know, actually have more touch points with patients because we could, you know, get in contact with them easier, removed some of those barriers that you mentioned with, you know, trying to get into the office, you know, having to couple babies visit with mom's visit. You know, it makes it a lot easier if mom, you know, we can just connect with her, you know, on a video visit. So, you know, it actually has increased the amount of, you know, contact between, you know, patients and providers. We're able to do that really quick postpartum screening. You know, we have maternal child health nurses that are, you know, really able to, you know, get in touch with and screen, you know, over 90% of all of our high risk patients. So all of our high risk patients, virtually 100% of them, you know, get some, you know, virtual visit from either, you know, a clinician or a maternal child health nurse, you know, within a week of going home. So I think that that was one of the benefits of, you know, COVID, was realizing that, you know, we really can use telehealth in, you know, creative ways, and that we actually can reach patients more and remove some of the barriers to them coming in.
You know, I just want to say one thing in response to this. I love that we have this technological resource for those who have the capacity to access it. But I wake up at night thinking about people in rural parts of Georgia and other rural areas that don't have computers, or if they do, they don't have enough resources to have that kind of access, and they don't have good medical care near them. And even though, Dr. Hernandez, you talked about some of the resources for people in such situations, but I don't know that we can even begin to think about how to respond. But I do want us to not lose sight of that while these wonderful resources that we're talking about, you all are in facilities with people who at least have computers and electricity. And we have in rural Georgia, people who barely have electricity and don't have a computer and don't have a doctor, and, you know, and have pregnancies. And I just want to put that in the conversation so that we don't get too far away from that. There's layers here that come right back to systemic racism and the disenfranchisement of poor people and Black people and brown people. And I want us to keep that thread very alive. No matter how many wonderful advances we've made, we've got to always put that in conversation with the folks that are being left behind.
And I think that's why it's important to look at, I recently saw this chart that I've been trying to find since I saw it at the conference that kind of talked about these areas that have like chronic brownouts, right? And this divide, because so much of what, you know, so much now has to be accessed online. And so I think you're right that you can't have this conversation without looking at digital access, you know, and Nielsen and Pew put out a lot of stats about how most people will access health information using a phone. So what does lack of consistent access do for you? And I do love Pew, PEW. I'll put it in the chat in case anybody's interested. They do a lot of great follow-up, but it also reminds us of who's still not connected, and communities where you chronically see lack of strong connectivity in those communities. And so, yeah, I love that you brought it back up because it always has to be a part of our conversation. I'll try to find that and put it in the chat while we're here.
And if nothing else, you know, I believe that it's in our consciousness. And so we keep being in discomfort about it, even if we can't think of today how to fix it. we know it's there in the back of our heads, and we don't get too carried away with what we have done, because we know how much we didn't do. And I just live in that, in the dissonance there that's created with, oh, it's wonderful, but look, all these people over here don't even know you did this wonderful thing.
Absolutely. And I think it's making, and I had a conversation with the governor's office about this. And I think with the infrastructure build and building broadband access, just being really intentional about who gets the resources. So like in Dublin, Georgia, there's only one OBGYN in 10 counties. And so what are we thinking about to be creative? And so we were thinking, we're talking to the governor and, some policymakers about mobile clinics, about sort of a uniform services approach to care for these populations, and then ensuring that they're not just addressing healthcare itself, but the social determinants of health, or as my colleague Daniel Dawes says, the political determinants of health, because we know, again, that structural racism, redlining, all of these things were purposefully done to, to discriminate, and, it's difficult. I think we're trying to get there. And I think with COVID-19, again, it brought attention to rural communities, and not, oftentimes people think rural communities are just white communities, when we know in Georgia in particular, a lot of our rural communities are Black communities. And so you add being rural, lack of access to care, and then being Black on top of it, it's that intersectionality that just creates a mess of health inequities. And I think COVID, brought attention to it, and we're trying to find solutions. It's just difficult when we still don't have those infrastructures in place. And that's why policy and advocacy are really important, that we're not just doing research, but we're ensuring we're just providing services, that we're speaking to policymakers, that we're making them accountable for the decisions that they make every day on our behalf.
Yes.
Thank you for, this conversation. I think it's really important. And Natalie, that kind of brings me, and everything Catherine and Tina that you were saying, to my next discussion topic. And I see a couple of questions in the chat that this might go under, is, they keep saying like it takes a village, right? But then COVID happened, and we were all told to like house like in place and get away from our village, or maybe our village was disenfranchised to begin with, right? So what, when you have this whole like it takes a village mentality, and we've talked a little bit about it throughout this town hall about, kind of teaching the teachers, or, teaching grandma, like what are some of the mental health things to look for in the new mom. I mean, what does this village even look like these days? Has telehealth, Tina, to what you were talking about, has telehealth coming up, has it improved the village, right? Because we get to have these like cool town halls, and we can actually like do face-to-face, and it's not just on phone. I don't know, has it hurt it? Or are we just like repurposing it? What is this village? What does it look like these days?
For me personally, I don't know what's happening, but it's actually helped me create a village with my neighbors. I think we were so busy, with everyday life, that you just sort of pass on and you wave hi. But I think COVID-19 forced us to have to rely on one another and create a pod. But then again, I'm a privileged woman, and so I know that those supports are not always there. I think, again, I think with the village, I think there are some ideas of it, but for everyone, their village is very different. So what's a village for me may not be a village for someone else. So that's for, anecdotally, and for me, I think it's helped me to understand that my village may not always look like me, but that I can lean on and have supports from other people that are surrounding me, and even within my own family structure. I think, supporting and working with my partner, we had to do it, otherwise someone was not going to be around, or the situation would have not been where it's at, because I, personally, I did take, the mental health load, and did have to seek counseling and stuff, because it was a very challenging time for me. as a mother, as an academician, and as someone who deals with other people's traumas and stuff. So that's sort of my take. I think there's some components of a village. I think people just access it differently.
And I think some people had to figure out, how to physically access the village, because you're balancing mental health and COVID safety and mitigation. And so I think it took people a while to kind of get their footing and figure out what it would look like and how to do it. I felt like we were back in kind of the late 90s when chat rooms became a thing, because then everybody, was like back figuring out how to virtually connect for many of us who had spent a lot of time, connecting. And so I think once people kind of figured out what this, I think people said a lot about new normal, and how we continue to normalize different conversations is important, as Natalie mentioned, like normalizing getting a therapist, and that's not like a slight, like getting a therapist is like, oh, like I need to get a therapist and go see my primary care doc, right? Like all of that is part of the conversation for people. And I feel like that is happening more. And so I think people expanded that a village isn't just relying on family, that your village support needs some professional support, right? Someone who's trained to listen and can leave all their stuff at the door. So I think that became a good part of the village too, I think for kids and adults, right? And I mean, good luck, you hear the struggles of people trying to find a therapist for their children, me included, but also knowing that that is something we're doing now, right? Like we know it's important and we recognize and normalize, like find someone, keep going for it. So we're persistent too. Yeah.
Yeah, we've talked and thought a lot about, this village, and, our term for it is really this, cocoon around the pregnant woman, and thinking from, the administrative side, we really thought that, the care of the pregnant mom, or really the layers of support, are not just, the OBGYN or the midwife, but really thinking sort of beyond, sort of the clinical aspect of, taking care of a woman and delivering her baby, but it was adding on, the licensed clinical social worker, thinking about and adding on, a nutritionist, case management, and really sort of expanding the people that are involved in the care of the mom and the baby. So that was some of the, a lot of the thought and discussions that we had from, more of an administrative hat, thinking about, within our, healthcare system, within Kaiser, and knowing that, there are a lot of resources available to us. How can we utilize those resources to really add to those layers, to create that cocoon around the pregnant mom.
No, thank you. So no, that's a excellent, those are excellent comments. I didn't know, David, from a pediatrician standpoint, the village, right? Because maternal and child health, like it doesn't just end, the child health, like you were already talking about with adverse child events, it does end at that 1 year follow-up, right? Like it keeps going, and it almost sounds like, right, it could almost bleed into like the prenatal care, right? It can bleed into the and you have this like ripple effect throughout the lifetime. And so I'm kind of curious in terms of the child and thinking of the child health, like what is that village, and kind of going off of what Tina and Natalie were already saying, what does that village kind of look like to ensure that, we're trying to take care of our children as well as, the moms and the caregivers' mental health.
Right. Yeah. So in some ways, it's kind of reiterating what was already said, and just to add on to that, obviously, as you mentioned, health-wise, prenatal care is very critical for the mother, obviously, and the baby as well, and that can impact the baby physically. As far as prematurity for the baby and developmental delays and other complications that can stem from that. So that's one element where the maternal child health is so closely integrated. But as you said, it doesn't end there by any means. There's obviously the health of the mother, being able to care for herself as well as her child and anyone else. That's a huge part of it, physically and mentally, psychologically, to have that. And then it also, a part where we get reconnected and think about the village. Obviously, if you have the opportunity to have extended family around, obviously grandmothers, grandfathers, things like that, I view them as a really critical piece, both from hands-on experience, but also historic knowledge about rearing a newborn child and cultural aspects of the challenges of having a newborn and being a minority woman and other things related to that, and also understanding kind of and being able to support some of the systems that can help the mother and the child do better. The other piece is that, chronically, in general, I view from a pediatric lens specifically, I always view basically having two patients in the room is the child, but also you have the parent who has to care for the child, and there's always a dynamic there that's important to understand both of those. And if the mom or if the parent needs help, I need to be able to recognize that they need help to be a better parent for the child in whatever way, and vice versa. And so I think to me, the maternal child health continuum it's ongoing. The child older and the mother and the parents are older and more experienced, but it's just a different dynamic, different social needs, different developmental needs, there, various things like that. So it's a matter for us, it's kind of like carrying the ball and kind of staying with it until they're adults in some ways. But I think lastly, going back to the prenatal piece and sort of the peripartum piece, that's a really, really fragile and critical piece. I think we can all acknowledge is critical, and we can always do better to make that more reliable, more effective, and more accessible for people across the board.
Yeah, and just going to Catherine about resources being limited, if you believe in the old age about it taking a village to raise a child, it's clear that there were a lot of people that that trusted her neighbors, or the schools that were open for free breakfast and lunch, to be that social safety net, for her to turn to her local agencies for help. It's easy to pass judgment on parents when faced with a paucity of options, making decisions that are based on not having any socially acceptable choices available. So that's why it's really important that we should, think about what a village means for a lot of people and not pass judgment on what that village is. But fighting for policies that ensure that there is childcare, that there is food, that our women are not criminalized for having to depend on their next door neighbor to watch their child because they have limited options. And so, Catherine, I just thank you always for making us think about, socially disadvantaged populations, or the structures that are in place that don't work for everyone. And we criminalize and pass judgment on those that don't have that, when our villages have always been our neighbors. And, I talk about the porch. I think we've used the porch more than ever. And it's like, hey, watch my kid while I go to the supermarket. Or, here's some change that was thrown down from the projects to go get an ice cream cone or something. That was my babysitter. Those were my neighbors that were just watching me from afar because my parents couldn't afford to have childcare options. Absolutely. I just wanted to just lift that up.
Thank you for bringing that up, because I think what that does is it connects to something that I've been thinking about a lot. I was in a conversation last week about health disparities historically in the Black community. And one of the things is that in communities of color, we have traditions of taking care of ourselves and finding ways to manage without resources that we've lost touch with because we got caught up in we're supposed to be liberated and everything's supposed to be modern. And so those old ideas are hokey, and some of those old ideas need to be gotten out of the closet and brushed off so that we can reconnect to some of those ways that we understood that we were supposed to care for each other. And I'm really advocating for let's not go back and find, but let's reconnect to those healing, the energy in those healing traditions that we have left behind, which include being careful to watch out for each other's mental health. We really need to reconnect to that, because mental health issues are, I probably would guess, are at a pandemic level themselves, if we really could talk to everybody. Because I mean, I think neurosis is running up and down the street naked these days, if you ask me. And we just need to be thinking about that, and how are we going to get ourselves back on the track here of caring enough to look at somebody and see they're kind of falling apart, and instead of being judgmental, walking over and lending them a hand, you know?
I think too, that's how you address the strong Black women, the challenge or the myth of the strong Black women, right? Which is allowing them to fall apart a little, right? And it still being okay. So thank you for saying that.
And I think real quick, I know that there was a question around kind of like access to services, and I didn't know Dr. Gibson or Dr. Jones, in terms of like Medicaid services, you know, if either of you all could maybe speak to like the pre and postnatal like services that Medicaid might provide for the mom. This kind of goes back, this has been like a thread throughout, right? Of like, how do we actually, like the community is great, the porches are great, the neighborhood's great. I really want to talk more and more about this and in part 2 next week, but also, you know, insurance is tough, co-pays are tough. Like, how do we get access to those trained medical providers, you know, Tina, like that you brought up. So I don't know, Dr. Gibson or Dr. Jones, if you can touch on that a little bit, our audience.
So I can start. So we do see some patients who have Medicaid in pediatrics, and there are services available. However, obviously, as we know, access to those services, particularly in behavioral health, is a perennial challenge, and you know, it's even more difficult with the greater need that's available. I can't speak specifically to as far as the prenatal or postnatal for the mothers. However, I would suspect there is availability, but the challenges, I'm sure, are difficult and unfortunately widespread. I don't know, Ericka, if you have any additional insight, anyone else, any additional insights in that space?
Yeah. You know, not a whole lot of insight, you know, for our patients. You know, everyone has Kaiser insurance. And so I think different from pediatrics, we don't see, you know, patients with Medicaid. I think with Medicaid, when you're pregnant, you can access care. But I think the question is, you know, what qualifies you for Medicaid, you know, and how you can get that care. You know, I definitely know that, you know, for some of our patients who maybe lost their insurance, you know, that has been difficult for some patients to, you know, find providers to see, particularly if they're transitioning care, you know, kind of in the middle of their pregnancy, you know, or even after delivery. It's been very difficult for people to be able to actually find a provider who will see them. You know, that's definitely something, if we wanted to continue this part of the conversation for the next part, you know, I can get more information and really address that question in more detail.
Well, thank you all for both. Thank you for the question, one from our participant, and thank you both for kind of addressing it. One other question that kind of goes to this village, right? And, you know, Natalie, you started, you know, you kind of brought up policymakers, and, you know, thank you so much, between you and Tina, you've been like putting in different like community initiatives in the chat. I appreciate that. But, you know, it can't all be, I think we've seen a lot of times, you know, when you think of the village, sometimes it always falls on the same person, right? Like the same high functioning, like volunteer, right? Ends up being like the go-getter for their entire family, right? And, you know, they're raising children, they're taking care of older parents, they're trying to manage their siblings, like it becomes a lot. And, you know, that anecdotally, but then also for clinicians and providers and social workers as well, right? Like it feels like it might all fall on the OBGYN or the pediatrician. And, you know, Ericka, you were talking about this before with bringing in, like having this multifaceted group. So I kind of want to think about, you know, one of the questions that we had in the chat was around, you know, what would you recommend as a productive, helpful change for like medical school and residency training, right? And we've seen this in other town halls around mental health and just trying to have more providers out there. But what, kind of thinking about that question around medical schools and residency trainings and making sure, how can we use medical school and residency trainings? And then also from a broader sense, because I want to get Natalie and Tina and Catherine, your all's feedback on, kind of just all trainings across the board, right? So I want to start with the med schools. I want to start with residency. I want to start this conversation there, but then really think of that broader, like how can we educate the broader community as well?
And Jennifer, we've only got about 5 minutes. So do we want to tackle this or save it?
I think it's great. Let's start this now. And it's a nice topic that we can pick right back up next week. But yeah, let's start. Ericka, David, if you all don't mind, we'll start with the medical school and residency trainings. And then, if we run out of time, we'll kind of talk more broader community education next Tuesday. That's a great point. Thanks, Catherine.
Yeah, I think that, obviously medical school and residency is really geared towards, sort of learning pathology and learning treatment, and you sort of learn the statistics and, you learn that there are disparities, but there's really not a deep discussion about why those disparities exist, other than somehow it seems like it's the fault of, the group that experiences the disparities. So I think that, in addition to learning the pathology, having, implicit bias training, I think is something that is really important that would help to address that. But also having those discussions, when we're learning about, maternal mortality and things like that in medical school and in residency, talking about that bigger picture, I think is something that you can do during residency to really kind of address those challenges.
And to add to that, I would say, in sort of instilling the concept and the practice of patient-centered care, I mean, continuing that. I know it's ongoing, but that needs to be embedded, because the opposite is, years ago we were trained to get the right diagnosis and treatment versus what do they need? What does this person in front of me need? And, beyond just why they were there with us, and then also really having, spending the time during residency and med school outside of the hospital itself or med school into the communities and actually seeing patients in those areas and understanding what the challenges and barriers and needs are, and hearing and seeing firsthand what people need.
Thank you for that. And then maybe, I don't know, Tina or Natalie, a couple like last minute thoughts on, other training programs or broader community education and engagement.
Yeah, as Dr. Gibson, so I'm not a physician, but I teach at a medical school. And so I work with our students and our residents around these specific types of trainings. Morehouse School of Medicine has a course that's required for all MD1 students that come in, that's about community health, that tackles the social determinants of health. Our mission is around serving the underserved. And so we're really thoughtful about the training that our students get through the 4 years, but then through residency and fellowship and other programs, they practice at a safety net setting. So I think medical school curriculum is starting to change and recognizing this, and the AAMC has made a commitment to address these issues. Let's see, we're going to hold them accountable for this, but I do see new trends and waves. And then there are also, continuing medical education. And so now we have Project Echo series where we're doing case studies and presenting case studies around disparities and inequities, particularly around mental health. And for instance, with ACOG, the AIM implementation bundles around mental health, around hemorrhage, and all the issues that we sort of discussed today. And then on the community side, we do a lot of interprofessional training. And so we have our physicians actually work side by side with community health workers, with PAs, with even basic scientists and population health scientists to learn together, because we're really thinking about integrated care and continuum of care. So those are just short things.
That's awesome. So essentially, ongoing continuing education, right? Like this didn't, trying to just unlearn and try and undo everything that, all the implicit bias that some of us have been faced with. I know that we are coming to time. I want to thank again our 4 very esteemed panelists for giving up your Tuesday evening with us. And Catherine, I will hand it back over to you and Dominique. But again, thank you. Thank you to all of the participants. Thank you for the very engaging questions. We're doing this again next Tuesday, so keep the questions coming. But yeah, thank you so much. And Catherine, Dominique, it is all yours.
So thank you, Jennifer. What a wonderful moderator you are. You really, I love your energetic enthusiasm in doing this. So we're going to have you do lots more of this, actually. And thank you all, Dr. Jones, Dr. Davis, Dr. Hernandez, and Dr. Gibson. And thank you, Dominique. And I'm older than anybody else here on this screen. So I have to say, all of you look like my students that I used to have in their first year. And I'm thinking they're all so smart, my goodness, and so young, but I know you've had time to get trained. So thank you. Thank you so much for the work you do, for caring for the people that you care for, and for not just doing mindless medicine, but for doing medicine that is holistic and concerned about the mind, body, and spirit of the people that you work with, because that's what this whole conversation has really been about. And all of you who've joined us tonight, thank you. Please visit our website, centerforracialhealing.org. You can go there and subscribe to our newsletter, subscribe to my blog, and take anything from that website that can be helpful to you. And if you should happen to have been lucky enough to win the lottery, please send us some money. We could use it. So thank you so much, and we'll see you next time. Good night, and thank you, Dominique. Good night, everybody.